in the emergency with the focal jerking of the left upper limb, which lasts for a few seconds, followed by um, loss of consciousness, right? And as per patients, as per the parents, the patient had fall and they observed extreme stiffness of the body along with jerking of the whole body. They were stung by post-ictal confusion and headaches, right? So Now it is okay. Right. Thank you. Okay. Uh, so we will start with our case. So presented with focal seizures with secondary generalization. And the clinical diagnosis was to rule out a space occupying lesion, and we went ahead with the CT scan. That is the first investigation of choice as the patient comes to the emergency. And all of us can appreciate that there is a ring enhancing lesion in the right frontal region with a bit of perifocal edema, which is not that easily visible on CT scan. And we can better appreciate it. This is a CT 1 year later. If everybody can appreciate, there is a small, a nodule inside the cystic lesion in the first CT scan. I'll tell you the importance of this later on. But this patient received the treatment in emergency, but 1 year later, he again presented with similar symptoms, and this time it is a thick walled circumscribed lesion, approximately 1.5 centimeter in size, in the same location. But now it has changed in character. Now, this is a point of concern. With the first CT, as we will discuss the radiology, things are quite clear. But with the second CT, things are a bit complicated because the radiologist invariably will say that it couldn't be anything. It can be NCC, it can be tuberculoma, or it can be any other space-occupying lesion. So there is a challenge in diagnosing these patients when they present atypically. This is a classical CT of a neuro-cysticercosis, but this is a bit atypical. We'll discuss why these CT changes are there in a given patient of neuro-cysticercosis. Okay. So the chest X-ray was normal. The MON2 was negative because the report always say NCC versus tuberculosis, and we are afraid of giving steroids without any anti-tubercular therapy. So this patient did receive phenytoin, which used to be the drug of choice earlier. Now you people are using more of levetiracetam, though we have proven in one of our studies, one of your MD colleagues had compiled the data of close to 150 odd patients where we compared carbamazepine with levetiracetam, and we showed that the efficacy is almost equal, but the side effect profile was much less with the patient who were treated with levetiracetam. So, so in the emergency, this patient at that time received phenytoin, and um, and responded well to treatment. So all symptoms improved, and it was later that when I showed you after 1 year, when he started having the similar symptoms, that we had to add phenobarbital and was investigated. This time the patient was given albendazole with steroids for a persisting lesion, and eventually on follow-up the lesion disappeared. So this is usually a classical case of a young male who presents with focal seizures, who receives, anti-epileptics and albendazole therapy under the cover of steroids, and invariably shows good results. But what about if the patient is a bit elderly? There is a problem. Now, this patient, 14 years, there was no witness. He presents to the emergency with one episode of loss of consciousness. Now, this is a challenge for everyone. How to go about it? There are some telltale signs, symptoms, which you can be alert while taking history. Important, of course, the patient in emergency will be investigated on the lines of whether it was a syncopal episode, whether it was a seizure, or whether it was a TIA. It becomes at times difficult. In a busy emergency, patient has fallen in the market and is brought to you with altered sensorium. How are you going to go ahead? So certain features like urinary incontinence, longer duration of loss of consciousness, post-ictal confusion, or tongue bite, these favor more towards a seizure rather than a syncopal episode. In syncopal, you can have incontinence in a very severe syncopal episode. Usually you don't have, you have a good bladder control. There is a history of diaphoresis, excessive sweating, and this way, you are clinically able to kind of differentiate between a syncopal episode or a seizure. But in emergency, if you are not getting history of tongue bite, urinary or fecal incontinence, or extreme stiffness of the extremities, or the patient was not a known case of seizure, then at times it becomes difficult, and then we keep our options open and start investigating. Of course, the first investigation in emergency will be, to clinically see whether there is any arrhythmia, any atrial fibrillation, or something of that kind. You go for a ECG. You look for evidence of any acute cardiac event, and just to rule out any acute cardiac event leading to syncope. And if not so, then you go ahead with once you stabilize the patient, you go ahead with the CT scan and try to find out if there is something wrong in it. A small bleed, a small strategic bleed, or a small strategic lesion, or a calcified lesion which is showing some kind of perifocal edema, which may point towards that this patient might have had a seizure also, right? So easier said than done. Invariably, all of you have come across such kind of patients, and it is really, challenging to pinpoint a particular diagnosis in the initial workup. Once your workup is complete, it becomes so easy to explain. This might have happened, this might have happened, but that is only, that is an advantage. Once the patient reaches a neurologist, you have most of the investigations done. So they have the advantage of having that workup already done, and you have to just solve the puzzle. But when it comes to an acute emergency situation, it remains a challenge, right? So these question marks will always remain, whosoever is there, who is the first to encounter the patient, right? I'm spending time because these are your day-to-day problems, okay? So we investigated this patient, and if you can appreciate, there is a disc enhancing lesion in the disc enhancing lesion with moderate perifocal edema. Now, this could have been anything. You cannot rule out even an aneurysm also. Okay, this may be just a contrast enhanced, aneurysm, which might have caused a bit of bleeding here and produced cortical irritation and produced um, seizure. It could be still be, it is so diffuse enhancing. It is not looking like NCC, as we had discussed in our first case. It can be a metastasis if this patient, if you have, somebody to give you a history that this patient is a chronic smoker and he had a loss of appetite or a loss of weight, then, there is nothing wrong even in keeping a metastasis as one of the differential diagnoses with such a big enhancing lesion. And it can, to our surprise, can be an aneurysm also, which is, picking up the contrast and looking like a disc enhancing lesion with the perifocal edema, right? So CT just gives us some idea about some pathology happening in the brain, but then you have to go for better modalities. MRI had always been there for a rescue, and most of the time it helps us in solving the problems, right? So, but we will discuss this again in greater detail once I touch the radiology. Okay, so from this, at least we are sure that this patient probably had seizure, and we start treating patient accordingly, right? And this is the follow-up radiology. This patient, after the initial workup, did receive albendazole therapy along with anti-epileptics, and this is the radiology 3 months later, which is absolutely fine now. So, but the workup had been the same as we did earlier. We did Monto, we did other things. We, of course, did, I have not shown the MRI, we did MRI, and that showed the evidence of neuro-cysticercosis, and this patient received albendazole, and that's the final outcome in these patients. So it is gratifying. If the diagnosis is correct, management is properly planned, then you do get very good results. Now, this patient, she presented in the emergency with recurrent speech arrest. She will have some funny upper limb jerking, and just speech arrest, and off and on headaches. No, young female, not classical seizures, and if the radiology is not available, or she's showing too much of anxiety, which can be there in certain areas of the brain if there is some edema or irritation. So this patient was, of course, by the resident mentioned as, hey, this seems to be a psychogenic case. Suddenly while speaking, she will stop speaking, and she will start staring, and then there will be few jerks in the right upper limb, and after that, after some time, she will spontaneously recover. So this had been going on for some time, and now because they had increased, so patient was brought to emergency, thought to be psychogenic, but then somebody thought, why not at least investigate this patient to see there is nothing wrong. And this is what was there in this patient. There was a left frontal ring enhancing lesion with moderate perifocal edema. If you can appreciate, this edema is more than what we had seen in the previous two radiologies. So again, the radiologist diagnosis is whether it is NCC or tuberculoma. But then we treated her. There are certain radiological features. Now I'll be discussing those in my next slides. We treated her like NCC. She partly responded to treatment, but the lesion was still there. And I think we repeated it again, and the results were gratifying at the end of 6 months. So this patient did receive carbamazepine. All of her symptoms disappeared. She received prednisolone, and under the cover of steroids, she received albendazole therapy, which is the standard of care, at least in PGI. But now the consensus is that we should give albendazole therapy in all diagnosed patients of neuro-cysticercosis when they are showing active lesions, right? In calcified lesions, there had been a debate, but the consensus is we don't give any albendazole therapy if the lesion is totally calcified, right? So after this management, after 6 months, most of her symptoms improved. Her repeat CT was absolutely normal. And over the next 3 months, this patient was finally tapered off all the medication. So that is the beauty of epilepsy secondary to a structural lesion like neuro-cysticercosis. So if there is a complete disappearance of lesion, which can happen in close to 70% of the patients, then we can think in terms of, tapering of the anti-epileptic medication within first year of starting the therapy. Normally, as you all know, we usually treat epilepsy at least for 3 years, especially idiopathic epilepsies or other symptomatic epilepsies. But in this situation, we normally tend to stop the anti-epileptic drugs if the lesion has totally vanished. So there had been a literature when the things were not clear, when the literature was full of vanishing CT lesions. That is how they used to be in the 1980s when first time CT scan came to India and we started diagnosing these patients. That time it was more, all of us were more inclined towards tuberculosis because that was rampant. But then there were certain radiological features which showed scoliosis, and we were able to diagnose them more like NCC and give albendazole therapy and get gratifying results without starting ATT. That had been a big debate in various groups across India. Bombay group had a different way. Delhi group had a different way. A Chandigarh group under the leadership of late Dr. J.S. Chopra had a different way and different thinking. And, we used to like to see the evidence of neuro-cysticercosis or cysticercosis elsewhere in the body. We used to go for X-rays of forearms and thighs and other areas if we could get any subcutaneous nodules to look for any calcification or evidence of cysticercosis. Our theory was that if the cysticercus has gone to brain, it must have lodged elsewhere in the body, and we used to find out the evidence elsewhere, which is not the practice nowadays. Nowadays, most of the time we are only dependent on radiology, and we are trying to develop some diagnostic serological tests, which still are not 100%, but or are very costly or not available. So most of the time we are either going clinically with radiology or some telltale signs of some evidence of cysticercosis, either in history or by a cluster Caesar approach. So this is in short the problems, challenges faced by a resident or a treating physician when a patient is brought to you in an unconscious state, be it of any age. But um, as I'll discuss in my next presentation, if time permitted, then probably we'll be able to discuss in more details how we can go about these ring enhancing lesions, right? So coming to the topic of interest today, what is neuro-cysticercosis and how um, it is affecting. So neuro-cysticercosis is the infestation of the brain by larva of the worm Taenia solium. It is the commonest cause of acquired epilepsy in developing countries, as I already told, right? And I didn't hang. Okay. Okay. So the clinical presentation depends upon the location of the cysticercosis, whether they are parenchymal or they are in the subarachnoid space or uh, they are in the ventricles or they are in the spinal cord. So why it is important to define the complete lesion burden, because in certain situations if we are not careful, then probably these patients may have flare up of their disease elsewhere and can lead to permanent deficits. Like in ocular neurocystic if we give albendazole, it can lead to permanent blindness because of the severe inflammatory reaction. Right. So we have to define the lesion burden before we plan a strategy, either by a good clinical examination or by radiological investigations, in addition to the MRI and CTs which the patient comes with. Okay. So then we have to see how many are the number of cysticerci and what is the evolutionary stage of the cysticerci. Depending upon that, we plan the treatment. It is found worldwide except for in Antarctica and Australia, where none of it has been reported. But of late, many Indians have immigrated to Australia, and there are reports popping in from that country also. And of course, their workup is quite exhaustive because the radiologists and the neurologists are not tuned to see. But again, the epidemiological history of movement from India have made them wiser, and they are now diagnosing more and more neurocysticercosis in their population also, right? So the immigration or the uh, this geographic data is very important um, in defining the nature of lesion in a given patient who presents with single ring enhancing lesion with epilepsy, right? So coming to Indian scenario, we are in the belt, which is quite endemic, and it is possibly related to the history of coke intake and things like that. Okay, and I want to emphasize a bit about the life cycle. The history of coke eating may or may not be very important in a given patient of NCC. Invariably, we ask for it, but this is not how the cycle actually goes. NAN is the definitive post. Definitive post means it it hosts the main worm, the Tinea solium. Okay, that's a large worm which is present in the large intestine, harbors there, and the man continuously uh, keeps on excreting the parasites, uh, uh, the proglottids, which contain a lot of eggs, and those are actually consumed by the pig. And into pig, these eggs then go and harbor in their muscles, what is called the measly pork. This is what I have shown here. So this measly pork, on eating this uncooked or improperly cooked measly pork, the man, again digests it and harbors the Tinea sodium. So the cycle is not completed for neurocysticercosis, if you can imagine. So man is just harboring the worms, excreting the eggs, and that is being consumed by pig. And consumption of measly pork leads to formation of Tinea solium in other human beings. Okay. So how did this neurocysticercosis come? It has to be by the ingestion of these proglottids or the eggs. So how that can happen? Either we eat the food material which is contaminated by human feces, meaning thereby that if we have, you know, fields which are irrigated by water contaminated by human feces. So all these proglottids or eggs in the human feces will stick to your vegetables, right? So eating raw vegetables which are not properly cooked is the major or the main source of neurocysticercosis. So it is. So I want to clarify you all again that it is not the eating of measly pork which leads to neurocysticercosis. It is by eating the contaminated food or raw vegetables which are laced with these eggs, and on entry into the humans, the human becomes an accidental intermediate host. So we can imagine if we are eating a food which is contaminated with these eggs, and this then goes to the stomach and then can go disseminate into the whole body. So that was our theory about diagnosing neurocysticercosis, doing x-rays of the forearms or thighs to find out evidence of cysticercus when a patient of ring enhancing lesion comes with the epilepsy, right? And hope I'm clear. This is very important. So how is human, you and me, acquiring infection? Suppose your mess worker is not washing his hands properly. So most of you are prone to neurocysticercosis. The man will keep on excreting the eggs, and if the man is not washing hands and is using the same for cooking food, you can imagine what is happening to you. Same is happening in various marriage parties. In one drum, they probably wash tons of vegetables without changing it. The same is probably not true at home. I think most of you can now imagine how we are acquiring and why unhygienic ways or improper ways are spreading this disease in the community, and it is quite endemic in India because of these food habits. You can see people enjoying golgappas, and the man is, putting his hand time and again in the same water and serving you all the same golgappas. And that is how, the disease is continuously spreading in the community, right? And that is why it is quite endemic, even in Chandigarh also. We come across so many, suddenly, a lot many students from PU, I'm talking of when the hostels were open, they suddenly, 5, 6 students will come in a cluster. And, the source will be a common mess worker who was not taking proper hygienic measures. So I just wanted to, in earlier, this was considered to be gobi ka keda. You must have read in newspaper also that it was called a cabbage bomb. But the fact is that people used to cabbages growing in the open fields, with contaminated with this fecal water, and so probably was harboring many eggs. And once you consume that, you are prone to have NCC. But that is not the only source. Any raw vegetable, whether it is carrot, radish, or anything, if not properly washed, which is taken raw, can be a source of neurocysticercosis. So I'm clear. I wanted to emphasize this just to, once we come across, it should not be a misnomer that people stop eating cabbage. It is only that we have to hammer that the vegetables have to be washed in good flowing water so that, all these contaminants can be easily erased. Okay, so again, coming to this, the pig is the intermediate host, man is the definitive host, and pig products, if they are infected and with larva, if they are ingested, we'll get tapeworm infection, not neurocysticercosis, right? If we take food contaminated with ova, we are bound to get neurocysticercosis. The other thing is the patient can auto-infect himself also, with bad cleaning habits. He can, contaminate his own food and can cause auto-infection. So the patient can have both tinea solium also as a worm and neurocysticercosis also. Or if there is some kind of a reverse peristalsis, that can also produce this kind of a neurocysticercosis. So you can have how you get neurocysticercosis finding. It is either by ingesting food or water contaminated with tinea solium eggs. Autoinfection may occur by means of fecal-oral route, as I'm explaining, or by reverse peristalsis in small intestine in patients who are infected with adult tinea solium worms. Greatest risk for infection occurs in regions where plants are fertilized with human feces and humans are exposed to contaminated soil. Okay, so in the stomach, these oncospheres, they are depleted and they invade the intestinal wall, enters the bloodstream and migrate and lodge throughout body, producing, these small fluid-filled bladders. I would like to show you some of these. We have grown in our lab in parasitology, and we have tried to make big worms also in our culture media. If I had time, I will show those to you also, where we have, artificially grown these from the measly poke from these oncospheres. Okay, so these are, they finally lodge, and wherever they are lodging, they will produce their symptoms. Okay, so the first stage, why we have those different CT changes is because of the various stages of neurocysticercosis. The first stage is the vesicular stage, where the cyst is live or active. It is growing, right? And the moment there is a degeneration, either because of the human immune defense mechanism or whatever inciting reason, sometimes, we have seen when there is a albendazole campaign going on in the schools, then certain kids, suddenly will come with epilepsy or seizures, right? So the theory is that probably albendazole killed that vesicular stage and produced the colloid stage, which has got a lot of reaction around the cyst and produces irritation of the cortex and produces seizures, right? So these are the various stages. The vesicular is a very nice stage. And then once the degeneration sets in, then it is called the boloid stage. And once it is, getting digested or it is dying, then comes the granular nodular stage. I'll show all these stages are well documented on radiology and on MRI. And then lastly, either the cyst will altogether disappear or it may leave its grave there, what is called the fibrocalcific stage or the dead or inactive parasite. But then it is a big pain in the neck of the treating physician because it is a constant source of a scar which can be epileptogenic under certain circumstances. So it's a big problem. So the vesicular stage, the colloid or the ring enhancing stage, which we have already discussed, shown. And then the granulonodular, where it is, diffusely enhancing. And in fact, the colloid one is the one which is diffusely enhancing. Vesicular stage in the early degenerative phase shows the classical ring enhancing lesion with the scolex, which is enhancing eccentrically, which I showed you in my first slide, right? And then is the involution, either it will totally disappear or it will, calcify. So this is what I'm talking about. This is a beautiful MRI, which is showing two cystic lesions, and you can appreciate scolex. And this is what radiologists are working on. Even one thesis is going on in the Department of Radiology now also. And the student is actually trying to look at the inside of what is there inside the cyst. And if he's able to document that scolex, which may be in a very different stage of degeneration or involution, then they can, with great authority can say it is nothing but NCC. So the focus is mainly on the scolex within the cyst, which is becoming a punchline for the radiologist to emphasize this is nothing but cysticercosis. Okay, and then these vesicles can take a big shape, like a hydrated cyst, as you can see. So this is the colloid stage when it is degenerating, and the scolex is also, showing degeneration. There is a rim enhancement and the eccentric scolex. And in the granular stage, as we saw, there can be a diffuse enhancement before it completely dies. And this is how it looks on flare, darkened. And in the otherwise, I had shown to many of you that it appears quite cystic when, we confidently are able to say in our OPD that this is nothing but cyst. But when it takes a colloid or granular stage, when it becomes dark, then it becomes a challenge for us even to, say. But otherwise, broadly speaking, whenever we are finding a lesion nowadays, which is less than 2 centimeters, has a beautiful rim, which is not corrugated and well circumscribed, then we confidently are making the diagnosis of NCC until and unless there is a compelling evidence to make an alternative diagnosis. Say a patient is immunocompromised or a patient is 70-year-old male coming for the first time with seizures, to offer a diagnosis of NCC with such kind of lesion is a very big challenge for a treating physician, right? So you have to work up for other causes of ring enhancing lesion. But in a young male who is coming with only seizures for the first time, preceding headache is there, then you are quite confident in 99 out of 100 times you are right that it is nothing but NCC. 1% error is always there. Like we had one patient admitted in our ward last week who was treated like NCC for 1 month. And then when she came with complications of meningitis and arachnoiditis and other complications that we had reviewed the case, reviewed the radiology, and finally made the diagnosis of tuberculosis, TBM with tuberculomas, right? So that is always there. But if we use more or less all the radiological entities which are available, which can differentiate the NCC from tuberculosis and other ring enhancing lesions, I think it is a good idea to utilize those modalities to make a final diagnosis because it has a big bearing on the life of the patient, right? Believe me, we have missed lymphomas, we have missed neurocystosis and other metastases and tumors in many of these patients who come with ring enhancing lesions. And you have to be very, cautious offering this diagnosis. But if you have a beautiful circumscribed vesicular lesion, which is of the CSF intensity, then more or less you are almost sure that this is nothing but NCC, right? And this is the calcification. Once it is there, you are always on the edge, stop or not stop antiepileptics and things like that. So that always remains a challenge. Okay. And then coming to, other varied, it looks fancy, but it is very bad for the patient. Usually these patients present either with raised ICP or some patients present with no seizures, but only cognitive decline, or some patients present with behavioral problems and intractable seizures. So we still are not able to find out why different patients behave differently. But this is how when a brain studied with neuro-cysticercosis presents clinically, and this is fascinating for the residents and for publication, but it is really bad for the patient. Of till date, we had been avoiding giving any kind of therapy and just giving low dose steroids and other things to prevent any of this cysticercus. You can see all of them are vesicular. Any of them can, get inflamed and produce seizure, right? So what to do with such kind of things? Had it been 2 or 3, we would give albendazole and, finish off. But when it is starry sky appearance, then it becomes a real challenge. But under supervision, neurologists have now started treating. The Lucknow group and Delhi group are quite aggressive. They are admitting patients for a month and giving them dual therapy with albendazole and praziquantel in a very escalated and a very under close supervision, because these patients, if all of them the cyst dies, the patient will die of cysticercus encephalitis in front of you in just 2 hours time. Imagine all of these cysts, they blast off. There is a lot of perifocal edema after giving albendazole, and the patient will cone in front of you. There will be herniation of this, and patient will die in no time. So the neurologist had been scared, but after giving a very good coverage with steroids and under close supervision, they had been giving albendazole with good results. Yeah.
এই জন্য বলে জানো তো, বাচ্চাকে যেরকম ভালোবেসে মাথায় তুলতে নেই, ফোনও ভালোবেসে মাথায় তুলতে নেই।
Okay. So then comes subarachnoid NCC, again a very challenging diagnosis. And I had shown a couple of you in the OPD also. We do come across, but they are really a challenge because they produce, if you look at this NCC, it mimics tuberculosis and produces a lot of arachnoiditis, and this can produce strokes, just like you see in tuberculosis. So it is really challenging. The radiology comes to your rescue when you have got a cystic lesion and you have fluid-filled lesions like the CSF intensity with a lot of perifocal edema around. You tend to think in terms of NCC, right? And they're really a problem in diagnosing as well as in management also. And this is, many of these kinds have been shown by in the OPD. This is, a bunch of grapes, knife grapes of cystic fluid intensity, which are producing mechanical compression. And, imagine it is putting pressure on the brainstem. There will be aqueductal stenosis eventually, and there will be hydrocephalus upstairs, or there will be pressure changes leading to cranial palsy. So it is a real challenge to first diagnose and then to manage also. I'll discuss that. Now look at this. There is a big cystic lesion in the fourth ventricle, and which is producing a lot of hydrocephalus upstairs. Not only here, there are lesions elsewhere in the brain parenchyma also, as well as in the Sylvian fissure also. And if you can appreciate, there is one in the third ventricle also. So these are real problematic cysts, which first are difficult to diagnose, and then second, they are very difficult to manage. And then same is true with the spinal cord. If you all can appreciate, there is a cystic fluid-filled like structure which is compressing on the nerve roots on the cauda equina. And imagine if I give albendazole, there will be severe arachnoiditis and there will be complete paraplegia. As of now, it is just producing symptoms mimicking lumbar canal stenosis and radicular symptoms. But the moment if we give albendazole therapy with or without steroids, it can really flare up like anything. And then you can have cysticerci within the spinal cord parenchyma also, where they present with various types of myelitis, and you have to be vigilant about this diagnosis. If you can appreciate, this is the ring-enhancing lesion in the high cervical region, producing quadriparesis, and the results were gratifying. Intraspinal, we are very comfortable giving albendazole therapy with steroids, and we usually get very good results. Many of the residents, at least senior residents, have seen such kind of cases. though they are very rare, right? And this is what I was talking about in yesteryears. This is how we used to diagnose cysticercosis. We used to get X-rays, try to find out evidence of cysticercosis to label the patient as Neuro-cysticercosis and give well-bendable therapy and not to start on it, right? So that had been the evolution of science over the years. So the clinical manifestations of most of us, we have discussed about it. They present with dementia, raised ICP, seizures, stroke-like presentation, hydrocephalus, or cranial deficits. And the single NCCs usually present with either seizures or sometimes raised ICP and focal neurological deficits as opposed to what we call the Todd's paralysis. And so it depends upon where the cysts are. Intraparenchymal, whether it is cystic or it is a calcified lesion, extraparenchymal, as we have discussed in the meninges, subarachnoid space, or with the arachnoid that is producing, strokes like, or in the ventricular space producing hydrocephalus, or in the spinal cord. I have not touched on in the eyes where it can produce, vision, transient visual obscurations or retinal detachments and things like that. Okay. So these are the common symptoms of seizures, headache. The seizures remain the most common manifestation. Headaches are other important. Say patient is having recurrent unilateral severe intensity headaches in the same location, that too of new onset, that too of increased severity, intensity, and duration. That is the time you start thinking of a pathology and investigate these patients. Then visual problems, confusion, ataxia, hydrocephalus, psychosis. So seizures can be varied, focal, multifocal, as I told you, just speech arrest. It can be a complex partial seizure or a simple partial seizures. Then focal motor, focal sensory, all kind of seizures have been on record and documented. And then depending upon its location in the temporal lobe or in the frontal lobe, it can be very short lasting, just for less than a minute, or there may be auras or hallucinations. So a good history and examination can give us a diagnosis to further probe these patients for a treatable cause. Okay. And then these patients, as I told, can present with mental disorders. And how to diagnose? We have got various tests, but we had of late been doing ELISA. You must have seen many of them. Many of us have been sending into parasitology, though they claim to have a very high CSF specificity, but we are not normally doing CSF if we are sure on radiology. Only few patients that we are not sure, that we send the CSF for ELISA. And Dr. Sehgal had of late pioneered, newer investigating newer diagnostic modalities. They have isolated the antigens and they have developed Western blot and newer techniques to diagnose, though it is only for research purpose as of now. But then if you have a doubt, then you can be in touch with that lab. They can give you a good diagnosis if you are in doubt. So we had a collaborative project with them, and we are trying to establish a solution for this common challenging problem. EATB is a costly investigation and not easily available, so not used in India, though elsewhere it is important in defining a patient as a definitive neurocysticercosis. Then is the detection of antigen. We are also in the stage of developing a PCR which can detect evidence of neurocysticercosis from either urine samples or blood samples, but it has still not been standardized. So as I discussed, stool sample may or may not be important. Nail fittings may be more important of the household workers or of your workers or your cooks, which may give a diagnosis to this public health problem, right? And you as doctors have to be vigilant. And of course, neuroimaging is the turning point. It is the modality of choice for diagnosis of these enhancing lesions. This is the whole list. I made a separate radiology. Maybe we can discuss it in some other some other class sometime, but it is quite interesting to discuss about ring enhancing lesions and the challenges being faced in an emergency situation. So all these, whatever I have written here, infectious causes, neuro-cysticercosis, tuberculosis, toxoplasmosis, brain abscesses because of various conditions, be it histoplasmosis, be it candidiasis, be it other atypical organisms. We have documented almost everything in a single ring enhancing lesion. Then metastasis, I'm sure if some residents are here, senior residents, they have worked up and they come with a diagnosis of a ring enhancing lesion, which is query tuberculoma, and finally they turn out to be CA lung. So, one has to be vigilant when you are dealing with a patient whose first presentation will be focal seizures, right? Or focal seizures with anti-generalization. In that situation, you do a radiology, you find a ring enhancing lesion, and then the saga starts. How to go about it. So the demographic profile, how old is patient, what has been the telltale signs, whether he had fever of long-standing duration, whether he had any history of weight loss or loss of appetite or evidence of immunosuppression. Suppose the patient is on, immunosuppressants or the patient has HIV. So the differential diagnosis keep on changing with the situation, and you have to club together to really reach a conclusion of neuro-cysticercosis. I won't say it is a diagnosis of exclusion, but there are radiological findings which are highly suggestive of NCC. But then at times, once I'm told, when you are in a granular nodular stage, then the differential diagnosis at times become challenging, right? So all of these can behave like a single ring enhancing lesion and become a challenge for us in real life situation. Okay, and of course CT, because it is performed quickly, gives us an answer, but of course it helps in finding out calcifications. Good, up to 75% of solitary lesions can be seen, except for, if you see and near the base of the brain where the artifacts are more, you tend to miss these diagnoses if the quality of CT is not very good or the windows are not properly set. So MRI is good in diagnosing, in following, and in looking at the glasses or a permanent damage if at all these lesions have made. And the question is whether to treat or not. The answer is a big yes. Now there is ample data in the literature to say that there is a role of anti-inflammatory agents, steroids, and under the cover of steroids, there is a definite role of albendazole therapy or anti-helminthic therapy. So it can be albendazole or it can be praziquantel. At times, the patient is not able to tolerate albendazole well. There is maybe an allergic reaction or there may be a hepatitis. Then praziquantel can be used. The dose is 15 milligram per kg in albendazole and 50 to 100 milligram for praziquantel. But it has to be given under the cover of steroids because the disease may flare up. And anti-epileptic drugs, in the yesteryears, we were using carbamazepine, phenytoin, and clobazam. But of late, we are using monotherapy with levetiracetam, and a new drug in our kitty is brivaracetam, which is coming up in a big way as a monotherapy also. And we need to, get more faith on these newer drugs. But as of now, still, if you see any neurologist prescription, it will be mainly carbamazepine and phenytoin, depending on the affordability of the patient. And of course, the newer congener of carbamazepine, oxcarbazepine, is also used in many centers as a first-line therapy. Okay, and so this was the story of ring-enhancing lesions, which was first introduced when CT was introduced in 1980s. You can see the classic scolex, and they were described as tuberculomas, as I told. This was from the Daily group, and then came, and then was the PGI group, and then another group which probably said that they are vanishing lesions and they are not they are not tuberculomas. So, but now things are different. And as regards role of steroids is concerned, they definitely reduce the number of seizures and help in better resolution of lesions on CT or MRI, and indirectly help in reducing the disease burden by reducing the duration of treatment from 3 years to maybe less than 1 year. Okay, so many randomized trials have shown the efficacy of steroids in resolving patients, in resolution of lesions in these patients over 3 to 6 months time. And of course, whenever there are breakthrough seizures, there is primary focal edema. We use steroids to reduce the comorbidities of headaches or focal deficits, which do appear transiently after a focal seizure. Okay, so these are the various studies, including one study in PGI in 2010, where we definitely showed the efficacy of steroids beyond doubt. Okay, but only steroids are when we have cysticercal encephalitis, as we saw, or in neuro-cysticercosis in the subarachnoid region, where it produces a lot of inflammation and vascular occlusion. We use steroids. And same is true for intramedullary NCC. I have shown you that meningitis is again like subarachnoid NCC. Then if we have documented vasculitis with strokes, we use large dose of steroids and followed by methotrexate therapy to prevent further vascular occlusions. Then if there is a communicating help hydrocephalus, then probably giving steroids may help in resolution of hydrocephalus, especially if it is a communicating type. And of course, as I mentioned, whenever we are using albendazole, we do give steroids, and we start albendazole under the cover of steroids. So there are a number of trials where they have shown the improvement in the outcome in these patients. So albendazole, as I mentioned, is given in the dose of 15 milligram per kg. We are using a 14-day regime. The recommendations are for 10 to 14 days. But in certain situations where the lesion burden is high, or we are anticipating that they may not resolve, and even up to a month, that people have tried albendazole therapy, especially in patients with in subarachnoid region and patients with complications of vasculitis and others, where albendazole is given for a longer time under the cover of steroids. And alternative is praziquantel, but of late, many studies have shown that if there are more than two or the lesion burden is high, then the combination of albendazole and praziquantel is much better. The outcome is much better in reducing the lesion burden. I think I have already overshot my time. I would like to stop here and would like to answer the queries, if any, from your end. Anybody?
Sir, what is the dose of the steroids and what are the choices of steroids which can use? Can we use prednisolone or dexamethasone?
Yeah, that's a good question. Actually, we are using prednisolone. Most of the studies have been with prednisolone. Like in tuberculosis, we are using dexamethasone because most of these patients are sick and we have to use IV, and Dexa is easily available and has a good CNS penetrance. And so tuberculosis things are different, but in NCC on an OPD basis, we are invariably using prednisolone, that too at a dose of 1 milligram per kg body weight. Our regime is that for the initial 15 days, one day prior we start the steroids and next day we start albendazole for 14 days. And then we rapidly taper it off over next 4 to 6 days time. So for 15 days, we give 1 milligram per kg, and then next 2 days we give half the dose and then 10 milligram for 2 days, and then we stop it. That is how we have been using in most of our patients, and that is how we had conducted a randomized trial also. Only in certain situations where the edema had been very high or the lesion burden had been very high, we use it for a longer duration. But otherwise, we tend to stop it after 3 weeks at the maximum. And that too, we are using prednisone.
Thank you, sir.
Any other question? Or any other query of some kind or any confusion? NCC is, though a simple topic, but very important to my understanding because there is a lot of confusion and lot of myths and lot of confusion regarding the diagnosis, regarding the management, regarding the anti-epileptic drugs, and regarding the duration of treatment, both of albendazole and steroids and anti-epileptic drugs also. If we are documenting that the lesion has disappeared, and with the support of many studies world across, we are trying to stop the therapy within first year of the disappearance of the lesion. Over next 3 months, if I have documented that after 6 months my MRI is normal, I'll start reducing the anti-epileptic drugs, and over 3 months I will totally stop it. So that is the importance. Another thing, why there had been a big school of thought that you are killing cysticercosis, which is already dying. So, is there any rationale of giving albendazole or praziquantel in that you are already killing a dead cysticercosis? But there had been studies where there are reappearing lesions that after 1 year you get another lesion in the same location. So the theory there was that probably there were many eggs which lodged in the brain. Some remained small, so they were the baby ones, and we couldn't find them. And the ones which had the swelling, they were visible on CT. And if you don't give albendazole, the other ones will pop up later on and can produce a new lesion, which was labeled as reappearing lesions. If you put in net, you will find ample in the literature. So that was the theory. So that made us more inclined to start albendazole therapy in any patient, irrespective of whether it is dying cyst or whatever. We are giving based on the evidence, right? Any other question from your end?
Sir, are there any risk
Sir,
factors to develop intraventricular NCC or the change of duration of treatment in that case?
Treatment, okay, I have not discussed, I should have probably, I have not discussed the management of intraventricular NCC. Intraventricular NCC, we don't tend to give albendazole therapy one because they produce a lot of inflammatory reaction. So rather than dying, they may produce more of ventriculitis and more complications. So the standard therapy, once you have diagnosed the patient as intraventricular therapy, is surgical evacuation, and then followed by or under the cover of steroids, followed by albendazole therapy, so that if anything residual is left, can be taken care of. Or some daughter cysts are still there, they can be killed after you remove it. So it is important to diagnose intraventricular NCC, but the management is surgical. Same is true for ocular NCC. I have not touched that. I should have. I think in the next slides, I probably because of time. So same is true for ocular NCC also. The modality of choice is surgical removal. You diagnose it through ophthalmoscope or through ultrasound, and then remove it because they can lead to permanent vision loss because of severe inflammatory reaction, which will damage your retina because they are just present in the different layers inside the eye. And once they produce this inflammation, the damage will be permanent because of the vascular damage and direct damage to the various layers of retina. That is how we are managing intraventricular or ocular neurocysticercosis. And regarding racemose, subarachnoid NCC, as I was telling, if the lesion burden is high, we tend to give albendazole for a longer duration. But that is only outside the ventricles in the subarachnoid space, where we are worried about, one of them may produce arachnoiditis and secondary vascular involvement and stroke-like phenomena. So in that situation, we tend to give albendazole with praziquantel for 1 month or maybe more and do repeated radiologies to look for the resolution. And then continue steroids or steroids plus minus methotrexate if the lesion burden is high or edema is there. That is how we are managing depending on those situations. Okay. Any other question?
Sir, does the treatment vary for single cyst or multiple cyst?
Yes, the answer is a big yes. For single cyst, we normally use albendazole for 10 to 14 days in the dose I have mentioned. And if the person is not tolerating, allergic, or has some, hepatic dysfunction, then we tend to use praziquantel. Or a patient who earlier received albendazole and doesn't show complete resolution, or there is a increase in the size or not resolving, then we do give praziquantel in that situation. But when the number of cysticerci are more, 3, 4, 5, 6, then we tend to give combination therapy under steroid cover. So that is the basic difference between single cyst versus multiple cyst and the management there. Okay.
Sir, should we start steroid later in multiple cyst group?
Before you have to always start steroids before you start albendazole or praziquantel, because you can never judge how the cyst is going to react. It may produce a severe edema and can produce raised ICP also, or can cause status epilepticus also. So that is why we tend to give it under the cover of steroids, so that the edema is not disproportionate and it can take care of any inflammatory reaction that can be produced by the damage. Right? Any other question? If there is none, we can leave the seminar, and whenever time permits, I would like to discuss the differential diagnosis of that also will take more than an hour, but would like to discuss and show a couple of cases where we had to revise our diagnosis once the lesion was not improving. That we can take up later in some class sometime, right? Is that okay?
Okay, sir. Thanks.
Right. Thank you very much, Sarthak. And sorry for all that trouble in the initial part. I had to use my wife's laptop. Mine was not working well. Thank you anyway. I enjoyed discussing with you this beautiful topic. Thank you once again. We'll
Thank
take
you,
leave. Right, thanks.